first two, you need to go through.
Well, and see, I can see from a patient point of view how one-size-fits-all breast cancer treatment does not work for what my personal experience was and what I've seen for the hundreds and thousands of women. Literally, I've met thousands of women since I've been diagnosed with inflammatory, had 6 months of chemotherapy, had to have a radical mastectomy, was slated to have 6 more months of chemo, but my response was good. So I was able to skip that, and then had daily radiation for 6 weeks. And when I was around my friends who'd had breast cancer, they're like, oh, wow, that is so much. I had a lumpectomy and immediate reconstruction kind of situation. And inflammatory has a totally different standard of care that I cannot stress enough how important it might be to our listeners to understand that.
Right. So, obviously, you should not have surgery up front. So that's a contraindication for sure.
Right.
You do have to get a systemic treatment.
And when you say systemic, you mean chemotherapy?
Chemotherapy to shrink the tumor, to get rid of the redness, and then really the engorged breast really needs to shrink so that you could do the surgery. Now, the surgery have to be what we call modified radical mastectomy. It's not lumpectomy, not taking part of it. It's not skin-sparing mastectomy. Skin should be not left. Skin, breast tissue, everything, lymph node needs to be taken.
It's the most aggressive form of mastectomy.
What's currently what we think is appropriate needs to be done. And yes, I do see sometimes patient going to the wrong type of surgery, so you need to make sure you get it. You need to get radiation therapy. I mean, there's no doubt you have to get radiation therapy at this moment.
Can you take a second to talk about why the radiation therapy is so important? Because with it not having a lump, with it being sort of scattered.
Right. So we don't know. So like I mentioned, the breast is red and engorged. And if you look at the section of these breasts, it doesn't mean that there's a pack of breast cancer there. So, but however, there's a small disease that's scattered all over the places, and we don't know exactly where that location is. So that's a risk for disease coming back. So the idea of radiation is to get rid of this any kind of small disease that could be hiding, so that you could zap that completely, so that it doesn't come back.
And I think that's very important because I don't think people realize that why you have such extensive radiation for 6 weeks, every day for 6 weeks with large radiation fields. Because, like we were saying, there's no lump. It's diffused and scattered, and so you have to catch all those little guys wherever they're hiding. Now, how do you feel about reconstruction post an IBC diagnosis?
Yeah, so reconstruction is a very important eventually, but the question is the timing, and because of the high risk of disease coming back, generally it is very difficult for me to recommend in the first 1 year to push for reconstruction. For sure, no immediate reconstruction. Even 6 months, I feel a little bit uncomfortable. Now, more than 1 year is at a comfortable range. That's something that the patient and the physician have to agree upon. One of the issues is that if the disease comes back while the reconstruction is happening, it is very difficult to take care of the patient because you're trying to do a surgery, you're post-surgery, and then you have, and then the question is this recovery from the surgery and giving another treatment, it gets very messy. So it is better to wait longer. And how long, I can't say it because that becomes a personal choice. But I could tell you that immediate reconstruction, 6 months, as if I was a primary physician, it's very difficult for me to recommend to my patients.
Now, when you mentioned reoccurrence, I think a lot of women might have the mentality, well, if I reoccur, I will deal with that later. But with inflammatory, the reoccurrence rate is somewhat quick in that first year.
Yes, the first several years, not just 1 year. Of course, the highest is always the first year. But the second year is the second highest, third is the third highest. It really stabilizes after 4 to 5 years, actually.
So that might be why some women may think, well, reoccurrence, if you're still thinking, kind of like with the standard breast cancer hat on your head, thinking, well, okay, I'm going to worry about recurrence later, way down the road, but IBC being such a different kind of cancer, reoccurrence rate is more immediate.
Right.
And so I think that knowledge is important for women to know, so they can maybe that knowledge can give them power to make decisions that will maybe not complicate their care.
Correct.
So that's an important thing to know, too. Now, from what I understand, that inflammatory breast cancer is not taught much in nursing school and medical school because they viewed it as too rare. Mm-hmm. Do you see any kind of movement to change that, or do we still have a lot of education to do?
It's a difficult topic to talk about. So the thing is, what do you want to teach to the nursing school or nursing school or even medical school? Okay. So what we need to teach about is that there's different form of breast cancer, and then recognizing the redness and the engorgement could be potentially still breast cancer. And that's probably the most important thing. I mean, the question is, should we teach all IBC detail how to manage? That's a different story because most school is not focused to become a breast cancer specialist. They're mm-hmm. focused to become a good primary care physician or primary care nursing is what we're focusing. So there's a need for going over one more time of the understanding how IBC presents, and that becomes a part of the differential diagnosis. So that's we still have to work on this actually. So.
Well, there's something that you're doing to change some of the education mm-hmm. about inflammatory. You've written a book.
Yes.
And so can you tell me about your book?
Yeah, so we have, this book is written by many IBC specialists from different parts of the world, and the idea is to provide the latest knowledge related to inflammatory breast cancer, including from prevention, diagnosis, treatment, biology, immunology, and we're hoping that it will come out late April. Yeah.
So it'd be April of 2012.
Yes.
Okay, and you can get it right. I saw it on Amazon the other day.
Yes, you could put Amazon and my name. Well, you could put inflammatory breast cancer, and then it should show up.
Well, I'm hoping that people will look for this book and get it into the medical libraries yes. and get it into their hospital libraries and just get it out there.
Right. So some of the first several chapters probably quite good for everybody to read to get a sense of how the disease presents, what the disease is about. The latter part, it gets more in details, and that's probably good for the breast cancer specialist.
Well, I know I'm planning on buying a copy. I want to get you to sign it for me.
Yeah, well, thank you.
Now, when we talk about inflammatory breast cancer, we've kind of run through the symptoms. Mm-hmm. So if somebody's tuning in later, they can know that it's a very outward kind of breast cancer in its symptoms. Mm-hmm. The breast can become red, hot, and swollen mm-hmm. quickly. Mm-hmm. You say it's period overnight or maybe over a period of a few months, mm-hmm. but still it's an outward sign type mm-hmm. of cancer. There can be a scratch mark or a bug bite looking kind of thing. Right. The nipple can go a different color, dent in. Mm-hmm. Breast can become very engorged. Mm-hmm. You may have swelling under the arm or maybe on that side up in the neck. Mm-hmm. Am I missing any symptom? No. And so if a woman presents with some symptoms like this, it's best that she get checked out as quickly as possible and not delay. Right. And then hopefully...
if you have that, clearly you have to go to a doctor. It's not... I've seen women letting go for a week or 2 weeks to see how it goes, and that's not right. It doesn't matter if it's breast cancer or not, but you need to see a doctor. That's not normal.
Well, I think women would just kind of blow that off and go, oh, I bought a new bra, and it scratched me, or it itched me, or maybe the underwire caught me, and so this is something you really want to caution women about.
Right. We're not talking about small redness. Really, the bra doesn't fit, and it's red, and,
Mm-hmm. So something more dramatic than that. Now, MD Anderson has got, like I said, the Morgan Welch Inflammatory Clinic mm-hmm. that was named after a young woman who mm-hmm. passed away, sadly, mm-hmm. Very young, mm-hmm. to this care. Now, MD Anderson's got a Facebook page where people can ask questions, and you answer those questions.
Yes.
For general questions, they can look that up on Facebook.
Right.
But also, too, MD Anderson has one of the largest biobanks for inflammatory breast cancer. Can you tell us about that and the research done here?
So what's important is to understand what inflammatory breast cancer is about. And currently I talked about all the potential presentation, mm-hmm. but for us to create new treatment, we need to understand at the molecular level or genetic level. And to understand this, because all cancer, including this inflammatory breast cancer, they could be different. So for us to understand this clearly, we need to collect samples from inflammatory breast cancer patients. So we have a bank system. It's like a regular bank, and you collect the tissue, and it's banked basically. And if we have a good research question, we pull those samples to analyze so that we could get the answer.